sharing their experience from tech leaders to tech leaders. This is CTO Talks.
Hello and welcome. This is Marcin Jabłonowski, and in today's episode of CTO Talks, my guest is James Reed. And since his role is not that easy for me to explain, I will let him introduce himself. And James, could you say, what do you do for a living? What your role is at the moment?
That is my pleasure, and thank you so much for having me, Marcin. So I work for the NHS, the National Health Service in England. So the NHS is actually UK-wide, but I work in England for the commissioning body called NHS England. And in that organisation, I run the National Digital Academy for Health and Care.
All right, so if you could just briefly explain what do you do for a living? What this role actually entails.
Yeah, no worries. So digital is becoming more and more a way of us doing stuff, all stuff, any industry, any job, any service, underpinned more by digital now than it has been, and it will be ever more so. We're in our trajectory heading upwards in terms of how much we're using data and digital support to support our work. There is a significant set of issues with using digital well, and many of those are addressed or impacted on by skills base. So skills base for senior leaders, for staff, for digital data and technology professionals. And my job is to source, find, build, commission the education that addresses all of those issues.
Okay, so what kind of skills are we talking about? Is it like the skills to use digital tools, or there's something more about it?
There's a little bit of that. So we think about a sixth of what we call digital capabilities are technical. But there's a significant set of skills which are much more about philosophy or culture that takes its root from looking at industries that work on the cutting edge of digital technologies, the Googles and the Amazons of this world, and look at what they've put in place to try and help their organizations deliver more value more quickly. So it's much more than just that. It incorporates the agile agenda, for instance, or the concept of user-centered design, or being data-driven, so seeking out evidence and data to inform better decision-making on a day-by-day basis, as well as things like digital literacy, so not just how you use the computer in front of you or the phone in your hand, but how you sort out good quality from poor quality information, or how you produce content yourself, or just how to make sure you're safe in interacting with these new technologies and concepts like the internet.
Okay, so to me it sounds like it has a lot to do with UI and UX design. Is it the case, or it's a wider topic? Not talking about the educational part, yeah?
Yeah, so UI and UX is certainly a significant part. Both of those two phrases, user interface and user experience, they come from a very technology-centric perspective. And so I prefer the phrase user-centered design or human-centered design, which itself, as I think you're probably aware, and your viewers will be aware, comes with its own international standard. We have a wide body of evidence about what this looks like and what it might be. But at its heart, for me, it's to help whole organizations and everyone in them focus on doing whatever they possibly can to deliver more value tomorrow than they did today through the services that they're responsible for. And we feel that there are a number of words that are conducive to that way of working. So user-centered is absolutely one. We're just not very good as human beings in making decisions based on what our users want us to do rather than what we want to do. Secondly, data-driven. We are still very knee-jerky in terms of how we make decisions and how we guide, in particular, the way in which we improve the services that we offer, and using data to inform how you design services and set up services initially, but also how you continuously improve them is super important. Then there's two other words that I will use around how we construct the teams that are responsible for delivering and improving those services. And the first is empowered. So something that we've really learned from the agile agenda, and in fact the high performing teams agenda, the OD agenda and the management and leadership agenda, is that individuals and teams who feel as if they can take decisions themselves are much, much more likely to give more and do better. And secondly, the concept of multidisciplinary team, or MDT. So if what I said right at the top of this interview, if that's true, if we are using digital and data much more now, and will continue to do so year on year in the delivery and the design of the services that we offer, how do we bring in those new sets of skills through new multidisciplinary teams as we draw on more of those technologies, data and ways of working? So that means that in health and care in particular, that's where I work, rather than thinking of an MDT, a multidisciplinary team, as being made up solely of clinicians, how do we help service owners or delivery managers or performance analysts or user-centered designers to contribute to the service that's being delivered for the net result of more value for the patient, the workforce, the taxpayer and the population?
All right, so we briefly moved to this, I would say, engineering. So considering the target audience of this show, which is like technology, IT leaders, the question that came to my mind, and you briefly touched the topic here, but what is the role of the engineering teams as well as CTOs or CIOs in the whole process? Yeah, that's because the process seems like a long path from like ideation, exploration, research down to throughout design down to actual implementation. Yeah, but what is the role of a CTO and the rest of the engineering team in this process?
So there's a whole lot in there. So I would say there are two key roles for engineering teams. So the first one is to consider that in the concept of an MDT, we would expect to see those sorts of engineering skills and, importantly, mindset to be part of every single team delivering every single service. Now, the NHS can't afford an engineer for every single team. So just to give you some metrics about this. So typical trust. In England, we've got 217 trusts. So trusts are small collections of 1 to, say, 3 or 4 hospitals that serve a catchment. Often will have a single name. There's that sort of thing. They may have as many as 400 different services that are being offered to patients as part of that organisation. What I'm not arguing for is, ideally it'd be wonderful to have an engineer as part of every single one of those teams. We just can't afford it in the public sector in the UK. But we do need to be granting access to those sorts of skills to help solve problems and encourage a different way of thinking at the service level. So how do we empower individual teams delivering individual services with all the skills they need in order to deliver more value tomorrow than today? So the first perspective there is for engineering teams to consider how they can make their skills available to others. The second is one of, I suppose, humility to an extent. So recognizing that engineering teams are there to solve parts of the problem here, how do they sort of recognize and serve those teams that are delivering services, sort of front of house services, I may call them, directly? So how do they consider how the sorts of, the ways of managing staff, the philosophy, the environment, the culture that, a CTO is responsible for creating to enable more value at the front line? So what the sorts of things I'm talking about here is the observation that digital in general is being democratized. There are now more digital professionals sitting within independent front of house business teams than there are under CIO or a CTO. That's just the direction. That's data from Gartner. And it's getting more so. We are democratizing more and more as, for instance, low-code, no-code environments become more available, as consumer technology becomes more powerful. Just looking at something like ChatGPT's launch last December, for instance, demonstrated how much consumer-accessible technology can change business function without having to resort to permission or support from a technologist or a CTO. So rather than fighting that, how does a CTO recognize that's happening and create a world where you're not providing a blocker to service teams developing improvements, but you do put in place the guardrails and safety so that those service teams who don't have the experience that a CTO or an engineering team would have don't make those fundamental mistakes or take those fundamental risks that cause harm to an organization, or in my case, the people in which we serve. No one wants to cause harm to patients.
Okay, so this is like about the potential blockage of the work, but from what you're saying, yes. So whatever you do, there is it's a value-driven process with a certain set of objectives that you try to measure. I have a few questions on that, but before we start, so like Agile also promotes this idea of, you called it empowerment, autonomy, making decisions like bottom up rather than up to down. And how do you, or do engineering teams contribute to these objectives? And how are the objectives usually defined? Yeah, because like when it comes to UX design, they have like certain KPIs. They can measure the usability of the feature. And here we're talking not only about the UX design, but also about the value of the service to the end customer. Yeah. So
we're taking a couple of steps back. So remember that healthcare is fundamentally it's a person-driven media. So you go and see your doctor, you go and see a nurse, you see a healthcare professional, and you get care as well as information or outcome. There's definitely a human interaction there. And a lot of the services, although they're increasingly being underpinned or supported by information systems and digital protocols, algorithms, technologies, it's still fundamentally a person business rather than a technology-driven business. So what I'd like to do is just take one step back. So there was a few things that you mentioned that's really, really important. First is value-driven. So technology is a means to an end. Increasingly, it helps us reach the ends that we need to reach, and it becomes more and more powerful. It enables us to do so. But it's not the reason for being. If there's a better way of achieving value not using technology, we should be taking that. And so I don't want anyone to assume or presuppose that the answer to any problem is a digital or a data one. Secondly, although the ultimate value for an organization might say static, so the value for a private sector organization might be making profit. For healthcare, we've got something called the quadruple aim. It's internationally recognized. And what it says is that there are 4 areas of value for healthcare anywhere in the world. The first is value to patients, and that usually means better health outcomes, better experience of health and care, and less harm caused. It's still a very dangerous industry, health and care. We do cause harm. The second area of value is the workforce. It's recognized as a value in its own right, an end in its own right, supporting a workforce that feels happy, that is well in and of itself. Is particularly important in the UK at the moment, where coming out of a COVID pandemic and with a lot of stress and strain on the whole system. Thirdly, the taxpayer. It's a publicly funded service, the NHS. And so it is absolutely necessary for us to have biggest bang for buck efficiency and productivity measures. And fourthly, public health. So recognizing that prevention is more effective and better than cure. It's better for someone not to have gotten ill at all than it is to have a good experience once you are ill. So that every single service in healthcare is about driving improvements in those 4 aims. But when you go down to, you mentioned KPIs and you talked about UI KPIs and things like that. For a healthcare service, it may be that you've got a user interface KPI, but that would be a rarity. Most of our services, let's say in a typical hospital, you might have an ophthalmology department, an eye department, right? And patients access the services. Maybe they're referred by a GP. Maybe in some cases they might self-refer. They might come through different routes. They wait for a bit on a waiting list. They are summoned to an outpatient's appointment. Someone looks in their eye with various lenses and things. They may or may not get a diagnosis. They may go away. They may have some treatment. They may be booked on for surgery. One of the KPIs might be how long it takes for that patient to get to a point where they're discharged from service or get to the point where they're able to get to their first treatment. Or it might be that particular service has spotted, oh my goodness, there's a whole bunch of diabetics here that we're not spotting quick enough and they're losing sight whilst they're waiting. So maybe there's a measure around outcome about having fewer people who become blind within 6 months of registering. So my point here is that the KPI, the thing that drives people, what we would call in Agile the North Star metric, is something that is absolutely focused on delivering a better service from the perspective of the user. If it's a solely digital service, and we do have solely digital services in healthcare. So, for instance, things like patient access portals, right? The service there is for a patient to be able to see their record and to be able to access it, contribute to it, feel happy that it's accurate. And there may be a UI metric, but it's a minority of services in healthcare. So what I'm keen on doing is bringing the engineering way of thinking and the agile way of thinking to any service in any industry. My job being within the NHS.
So from what I'm hearing, it's like, unlike in many digital products, which are, for instance, web applications, the value here and how you measure the success of a service is way more. So it also entails like human interaction. So that's even more interesting, even to engineering teams, I believe.
So the important thing here is that digital and engineering teams, they've got an insight into how to make things better. And because of the tools that we use, the digital tools we use, it's easier for us than for anyone else to use data to inform our job. It's helped by the fact we work in a very, very data-rich environment, and we're staffed by people who really understand data. We've got the minds for it. It's harder. It's so much harder in other services because it's harder to collect data in the first place. It's harder to find true North Star metrics that's measurable at all. And even if you can do those things, the rate of collection of the data that you want is normally a manual process, and you may be able to measure a data point once every 3 months or something. I mean, that's hardly rapid, is it? When in the digital world, we'll be looking at user interaction on a day-by-day, hour-by-hour, minute-by-minute basis in some cases, and you can make changes based on what you're seeing almost in real time. You just can't do that in a lot of services. Nonetheless, it gives us a framework to work from. So engineers can share that way of working and those expertise with other business unit services, and broker that arrangement. Engineers need to be part of the multidisciplinary team.
There's one question that comes to my mind regarding what we just discussed. So healthcare is quite a unique, I'm not sure, not industry, but part of the life where there are many people in difficult situations, and once you start digitalizing healthcare, that's one question that comes to my mind: how to avoid like dehumanization of the process, so that people are treated like human beings within the process, and they don't, for instance, I don't know, one case that comes to my mind: someone is diagnosed of cancer, and he gets a notification of that digitally via email. So I believe it's like quite a tricky thing to balance how to digitalize these services in a way that we are still feeling like human beings.
So the engineering world has the answer to this again, and it is human-centered design, right? So if you design services on the basis of speeding up a process, you will get to the answer of every cancer patient receives their diagnosis directly from the pathology lab via email or text. And you can see that might have an impact. If you take the perspective that speed is a factor, but actually so is delivering information well, and crucially, meeting your users' needs. That means fundamentally understanding who are these people who are coming through, who you are serving, understanding what their needs are. In some cases, that might be, you know what, I'm emotionally resilient, I've got a really strong network around me. I've got my partner, my family at home with me. When I read my email, I'm surrounded by those people. Oh, and by the way, I can also call my GP on, I've got a phone number that I have some faith will be answered. It might be wholly appropriate for an individual to receive a diagnosis of cancer remotely through an email for that individual. entirely different situation. An entirely different situation might be whether someone who doesn't have that support, who doesn't really understand cancer, isn't expecting the outcome, gets it and is, completely not for six. It would be wholly inappropriate for them to receive an email about it. So tailoring a service to meet your users' needs is fundamentally part of user-centered design. You went a slightly different way with that question than I was expecting. I thought you might talk about digital exclusion and what happens if you don't have the right skills to access a digital platform.
That's next on my list.
Okay, fair enough. Well, should we go there now?
Let's go, because healthcare is unique in a sense that its, I would say, user base is, I would say, unbalanced compared to others. So probably most of clients of healthcare services are elderly people. And I mean, it applies to all industries now with the aging society, where elderly people very often are being forced to learn this kind of digital tools, and not all of them have the skills and capabilities to do that, right? So we're talking about potentially a digital exclusion. So how do you deal with this? With this problem?
Yeah. Okay. So there's a number of things to touch on there. So firstly, let's explore the digital exclusion problem for a second. So in the UK, we're lucky enough to have a bunch of data. We're in the process of collecting some ourselves around the digital literacy of the workforce. There's an organisation called Future.now that works with Lloyds Bank in the UK to conduct a poll every year, actually, on the digital literacy of the workforce. And what it's concluded is that 8% of the workforce, about 3.2 million people in the UK, and we've got about 60 million people, I think, probably about 30 million in gainful employment, have no basic digital literacy skills. They're probably unlikely to be able to use a computer, a mouse, or a phone to access the internet. You've probably got another 14% or so of the population who've not got enough digital literacies to be safe online even. So very, very basic digital literacies. Lloyds and Future.now have got 20 what they call essential digital skills for work. And this is, so about 14% of the UK workforce has got between 1 and 4 of those 20. So that's, it's a small minority of what people need. About 78% have got 5 or more sort of basic essential digital literacies. And one of the interesting things is digital skill set, digital literacy varies. It does vary by age, and you talked about the aging population. But actually, to be able to essential digital skills for work don't peak at the very left-hand side of your timeline. It's about when you get to 28 that you peak. And there are people at all levels, and in fact all levels of seniority, who just don't have the right digital literacies for work and increasingly for life. And although there is a correlation with age, it would be incorrect to say it was the strongest correlation. There's a stronger correlation between digital literacy and the industry in which you work than there is between digital literacy and age. That all said, all that does is highlight there is an issue that you've just articulated, which is there is a proportion, and it's not an insignificant proportion, of the world's population that doesn't have the skills to enable them to reliably use technologies in the way that we might presuppose they could. So what do we do? Now, I don't actually think this is exclusively a health and care issue. I mean, in private sector, if it costs you a penny to interact with someone digitally, and a pound, 100 pennies, to interact with someone face to face, then you want to try and push as many people to the cheaper route as possible. And in fact, you might choose to forego on the 5 to 10% of people who can't access your services digitally, because why would you pay 100 times as much to help them otherwise? When you're in the private sector, you can make that decision. You can provide an unequal service. In the public sector, whether it's healthcare or whether it's local government or whether it's pensions or I don't know, workforce services, whatever it might be, social care, social services, you can't do that. So you have a duty to serve your entire population. So what that means is you need to diversify. What you might call in the private sector omnichannel. You need to provide as many different ways to meet your users' needs if there is an exclusive limitation for your user. So if you've got a section of users that can't use any device whatsoever, you need to be able to provide a channel where they do not have to use any devices whatsoever to interact with your service. And that's what we do. So where you've got an online service for 111, for instance, which is the NHS's symptom checker, and it's a pre-emergency service, basically. It's where you don't know what's going on, but you don't want to call an ambulance yet. Then you can go online to check whether your symptom, what your symptoms might be, and where you should go get some advice. You can make a phone call. So if you're no good with digital devices, you can use a phone. If you can't do either of those things, then obviously we've got accident emergency departments, but we've also got urgent treatment centres as well. So this is like the next step down, where it's not quite as urgent as A&E, and you physically go to it. It gets progressively more expensive, of course, to deliver services, the more that you have people delivering them and facilities. But when you work in a public sector organisation, you simply have no choice. You've got to deliver services for your users. You can't just deliver for the ones that it's easy to deliver for,
and regardless of the cost.
Unfortunately, and what that does mean is you need to make compromises elsewhere. There's a limited amount of money.
So how about not only like the lack of digital skills, but the other thing is, I would say, the increasing complexity of digital tools, basically. Yeah? So the world is getting more complicated. The number of tools is increasing. Its feature sets are increasing. So I would say the number of services provided, what you said about these hospitals. So people can get easily lost, even those having the digital skills. And so how do you tackle this thing? So, the increasing complexity of digital tools and potentially, I don't know, its simplicity to use or...
Yeah. So it's an interesting observation, because there clearly is increasing complexity. We can do more with what we've got because we've got more than what we had. Moore's law still applies. We've still got twice as much opportunity every 2 years. But things are also getting more usable. It's getting, the science of understanding how to help people use stuff. And the fact that we've got a standard around human-centered design is brilliant. We didn't have that even a short number of years ago. So what we're doing is two things simultaneously. We're massively diversifying in terms of complexity of the services offered, and we're massively simplifying in terms of how each of those individually complex services interact with the people who need to interact with them. So I mean, even coding nowadays, whether it's low-code, no-code environments, or whether it's using ChatGPT for coding, right, which is its single biggest use case, is using AI to draft code. It is easier now to do even the complex and creative elements of the technological world because of that user interface design. So it is both more complex and easier. And actually, the net result is we can make more use of more of those tools by more people. It has two knock-on effects. So the first one is you get far more specialisms. There's a huge broadening out of specialist skill sets because there's a huge broadening out of the number of technologies in play. The second is impact when things go wrong. When things go wrong, it is much harder to troubleshoot if you've not also tried to fix the troubleshooting mechanisms with that human-centered design, that usability frame of mind. So it's got to the stage where if it's not your area of focus and there's no help, it's almost impossible to troubleshoot yourself, because it is now this thing with this set of skills linked to this thing with this set of skills. You can't be an expert in everything anymore. And that means that when things go wrong, it's harder to fix stuff.
And probably, because even with ChatGPT that you briefly discussed here, so once you don't know how things work under the hood, I believe, even with ChatGPT, AI, or any other tool, there's also a number of threats that's coming, like, security, multi-factor authentication. What are the biggest threats you see in this kind of digital transformation processes or digitalizing healthcare?
So, I mean, it all stems from putting more power in more hands. The threats are the same as they ever have, so human factors and making mistakes yourself, or external actors trying to impact on you, the cybersecurity risk, that sort of stuff. It's so the human factor stuff could be, I mean, this is not my area of expertise really, and I believe it's the same sort of level of threats as you might have discussed 5 years ago, but anything from accidentally exposing information to breaking systems to compromising security, to, all of those sorts of things I would put under the human factor stuff. And it becomes easier for more people to do that with more impact, the more tools you've got. The job of the engineer in this case is not to prevent people from doing things, actually. It's not to stop people in your workplace using ChatGPT, even though if people use it incorrectly, you might be putting a whole bunch of entirely secret confidential information into a different system that other people can access, or you might be getting an incorrect answer and giving people the wrong advice, which in a healthcare environment can kill people, right? There's a big problem. These are significant risks, as an example with ChatGPT. But the answer is not to prevent people from using it. The answer is to put the guardrails in place to help people use it safely. So otherwise, you won't get the value of these tools. Something we've not talked about yet is skill sets for senior leaders, digital skill sets for senior leaders, which we think of as the cultural environment to bring about both a user-centered and a data-driven environment. It's how you do things safely, but also quickly. How you have an innovative environment that isn't stifled by saying no all the time because that's the best way of being safe. And my biggest criticism of not just engineering teams actually, but anyone who's in a sort of a position of a centralized team that's got any sort of responsibility for governance, is that it's really tempting to say, this is risky, no, you can't do it, rather than this is risky, this is how I'm going to help you get the value, and I'm going to help everyone get the value whilst minimizing our exposure to risk. And it's a lot harder to do that, but that's the only way that organizations are going to continue to be competitive and innovative.
So when it comes to risks, as healthcare and anything related to healthcare is tackles with sensitive data. Yeah, it's commonly considered as sensitive data, medical information, like that. So before we move on, maybe you could, because I think it varies from country to country. So could you briefly say how does the digital information about healthcare patients look like in the UK? Because for instance, in Poland, there's nothing almost, but I believe there's quite advanced. If you are able to make conclusions based on the data, I believe you gather the data. So if you could just briefly say, how the medical records look in UK, is it centralized?
Yeah, no worries. So each trust, such group of hospitals, they will have, I think it's more than 95% now of trusts have got their own electronic patient record where you've got digitized patient information held and shared across a trust for the reasons of delivery of healthcare. Every single general practice in the country has access to one of a small number of GP systems that enables you to collect and share information that's similar on patients. And we have now grouped health and care and social care organisations into what are called integrated care systems, with the view of facilitating information sharing and also streamlining services between different health and care providers, so that individuals have got a much better and much more streamlined experience between different providers. There's also a subset of data which is collected and held centrally in a shared summary care record. And that's accessible anywhere in the country as long as you've got the right permissions. Historically, that's always been something you have and something a card, actually. But we're in the process of modernising some of those bits and pieces as well. We do not have a fully shared full record across every single health and care organisation yet. And I think it's fair to say that we've always taken the threat of exposure of that data extremely seriously. So we minimize the risks of exposing any of that data anyway.
Yeah, by decentralization, basically. Yes.
Over centralization offers a very tempting target, and it doesn't always provide all of the benefits. So what we've got is it's a federated approach whereby integrated care systems have got responsibility for a catchment. So it's kind of the best way we think of getting that balance.
And now a question you may refuse to answer because you may not be able to reveal this, but that's interesting thing from my perspective as an engineer. You said a lot about making conclusions based on the data. I believe it's statistical data. So where do you get this data from? Because I believe there's a large number of information. It doesn't need to be sensitive data, but if you want to measure the value of the services provided, you need to take the data.
So when I refer to data, I'm not just talking about quantitative data, actually, not just data you can count, but also qualitative. So testimony, opinion. What I'm trying to avoid and what I'm trying to draw a distinction between is perspective-informed decision-making. So where someone who runs a service says, oh, I've seen a lot of patients, I know they need this, to data-informed, which is, well, should we go out and ask some of them? Or should we do some contextual user-centered analysis by going and sitting in outpatients and watching the flow and seeing what time people come in and how long they're waiting, and are they on their phone, or do they look frustrated, and are they leaving to go and grab a sandwich or go to the loo, and do they miss an appointment because of that, and all of that sort of stuff. So you can be data informed without it being underpinned by complex statistical modeling. There is, of course, outcomes data. So I think you're referring to use of the patient record as a source of data to inform service redesign, for instance. And there you might be looking at outcomes data. You might be looking at activity data, how long between GP appointment to diagnosis. When I first started work in the health service, which was a long time ago now, about a quarter of a century ago, the cancer plan was launched, which announced a number of targets around presentation at a GP to diagnosis and first treatment, with the aim of bringing down these pathways. Obviously, cancer is a disease that progresses, and the longer that you leave it, the worse the prognosis is. So there was a big push to redesigning services at that time in the early 2000s around making things shorter. And we can use that sort of data to inform those sorts of things as service redesign, capacity and demand sorts of challenges. But I wouldn't want to pigeonhole use of data into just one tool. It could be capacity and demand analysis. It could be user-centered design. It could be key performance indicators or success criteria. There's lots of different ways data can be used. My point is, let's try and use data to inform decisions, not gut instincts.
Yeah, I totally agree.
You would. You're an engineer.
Exactly. Part of your role is also an education on digital skills, right? Is there any way that engineering teams can contribute to this process, or they can support this educational process?
Yeah, of course, yeah. So what I should say is, just like engineering skills are a profession, and actually, we saw this in the .com bubble. Everyone felt, coding, I could have a little bash of that. Everyone had a little bash. And a lot of people who are, professional digital data and technology people, specialists, quite affronted, quite insulted by this concept that anyone can have a go at their digital stuff, can't they? In the same way, education is a profession in its own right. So what I wouldn't expect is anyone to become an in-depth educationalist without a significant amount of training. That said, so one of the things that we do in the Digital Academy is we try and develop training that has biggest bang for buck. And one of the hardest problems we have is finding people who are able to deliver face-to-face training. E-learning is really scalable and it's really cheap. It doesn't have the same impact or the same draw. You don't have this sense of feeling of a treat.
And it's not as accessible.
It's not fun. It's not as fun. Then you've got face-to-face training, which is, in comparison, phenomenally expensive. It might take pennies, if that, to deliver an e-learning module to a person. It might be tens of thousands of pounds to deliver a year-long postgraduate diploma, right? They're totally different ends of the spectrum in terms of cost. But what we've been trying to do is work out whether we can create almost like train the trainer modules. So take an engineer who really knows their stuff and then provide a set of training materials for them to teach other, apprentice engineers really what it looks like to do the job. So we've been working, particularly in the digital data and technology world, with heads of profession in government to try and determine curricula for new individuals coming through. And these are skill sets that are vastly in demand all across the world. We've got about a 10% vacancy rate in the UK at the moment across all industries for digital data and technology roles. So how do we encourage people, school to take STEM subjects, at university to take, engineering degrees? And when they take their first steps into the workplace, can we provide train the trainer type packages of learning? So an engineer who's not an educationalist can deliver a structured curriculum of learning to a number of apprentices and help them on with their learning. So yeah, I do think that that's one way in which engineers can contribute to the education environment. The other is the softer approach to education. So the more engineers spend time in frontline business services, I talked before about this concept of service-centric multidisciplinary team working, the more that you can expose people to engineering ways of thinking, ways of solving problems and skill sets. Not I'll solve that problem for you, but in have you thought about breaking that problem down into its constituent parts? Have you thought about mapping out your process? That these sorts of logical ways of thinking, which engineers bring to their work naturally, but others don't.
Yeah.
It's a real skill set that isn't hard technical skill, but it is a way of thinking that engineers can bring that can really supplement a multidisciplinary team of the future.
I know it's also a trend of adopting agile methodologies, not only in IT. I know there is a program called Edu Agile, where you try to adopt agile methodologies in education, basically. So that's one example.
Well, so when we use those principles, we think they're applicable everywhere.
Exactly. Listen, we touched very briefly a very hot topic nowadays, AI. Yeah. We talked about ChatGPT, but I need to ask this question: where do you see the potential of adopting AI in healthcare?
Oh my goodness! So,
if you're not prepared to that, we can just.
Gartner estimate that we're right at the top of the hype cycle for AI at the moment, which means everyone can see lots and lots of potential. And what we always do is overestimate what can be done in the short term and underestimate what can be done in the long term. And you've asked me a long-term question, so I'm going to say some stuff and it's going to be completely blown out of the water in 5 or 10 years. Mm-hmm. What I'll do is I'll give you some examples of where AI is used right now, if that's okay, that I would expect to see much more in use in future. So one of the things that artificial intelligence, these sorts of algorithms are really, really good at doing is spotting patterns that humans can't spot. And in particular, where we've used it in healthcare at the moment is in image analysis. So in pathology, in radiology, x-rays, CT scans, that sort of stuff. And in ophthalmology, we take pictures of the eye. Then computers now, if trained correctly, can spot anomalies better than trained human beings. And this has been demonstrated in a number of studies. Not every single one, right? So at the moment, it's not perfect in every way, but it certainly indicates to me that we are likely to see individuals whose job is involves image analysis at the moment to be supported by AI much, much more in a very short timescale. So it's being operated in islands right now successfully. So I would expect to see those sorts of innovations happen really quite in quite short order, notwithstanding probably the biggest issue that we've ever got is in rollout and implementation. Getting a good idea here adopted everywhere. It's always been quite tricky. I would expect to see more of that when we start being able to pull together data sets from different environments. So, for instance, being able to use social care and local authority data to spot frailty issues. One of the biggest indicators of a potential fall, which is often the thing that triggers a sharp decline and death in the elderly, is whether they're on the register for help from local government to take their bins out. So if they're on the register saying, I need some help taking my bins out, it means that they are frail, they're likely to have a fall, and it's the biggest indicator that we have got to predict falls. So it's just an example of what might happen when we start to pull data sets together across different public sector environments.
Great. Maybe one question on a funny note. Have you seen already, you're not a doctor probably,
I'm
but
not a doctor,
you may have access to some information that, like I would say, results of self-diagnosing people with the use of ChatGPT, for instance.
So I have looked at the use of ChatGPT in diagnostics. I am reminded that a large organisation, Babylon Health, has recently gone under because it made certain expectations known that their AI algorithm was able to do things like this, and it wasn't. I looked at a couple of blog posts from junior doctors working in emergency departments, putting in a set of symptoms into ChatGPT, and ChatGPT got many of the diagnoses right. So out of 20, I think 15 it got right. Out of the 5 it got wrong, 2 of them were wrong to such an extent that that individual might have died. So there is, like I said,
So that's a warning.
Like I said,
warning.
The biggest issue about health and care is quite simply the most dangerous industry in the world. If you get things wrong, people die. So you need to make sure you've got the guardrails in place. Now, the guardrails in place, I don't think this would happen, but if you were to use ChatGPT as a triage tool, having a human being check might be a way of putting a guardrail in place. We know it's not perfect, those sorts of things, but
so what you're saying is not to ban these new tools, it's just to make them safer to use.
That's
yes?
correct, and use data to inform that.
All right. Wrapping things up, what would be like an advice you would give to anyone in a senior leadership role in IT or in engineering, given your area of expertise?
Okay. Firstly, try and be curious. Most engineers don't have a problem with that, and also humble. So try and understand what your business needs, and then try and understand where you and your team can add your expertise to help them solve their own problems. Don't assume you're going to solve problems for them. Help them solve their problems. Secondly, make sure that every piece of work that you do is aligned to your organizational strategy. I can't emphasize that enough. That often we develop digital tools and digital strategies in a complete vacuum because we've got no way of linking that through to organizational business. And so making the link is super important. I was a chief digital information officer for 8 years. It's the hardest thing you can do, but it's also the most important part of your role. And I suppose finally, what I would do is encourage your teams to spend time with your frontline business. Strategy's fine, but experience is much better. And relationships really facilitate that. So when people start to trust you, you start to get that empowered team environment. You start to get that multidisciplinary team environment. And you're much more likely to get an interchange of ideas and perspectives and get those leaps forward in value add.
All right. James, many thanks for joining CTO Talks. It was an incredibly interesting conversation. Not purely engineering or technical, which is, I think, also a good change. I hope we have a chance to speak again.
Thank you very much, Marcin. I've really enjoyed it, and thank you so much for inviting me.
Sharing their experience from tech leaders to tech leaders. This is CTO Talks.